Hello, and welcome to the Two View, the cutting edge educational show for PAs and nurse practitioners in emergency medicine and urgent care. I'm your NP host, Martha Roberts, and I am a practicing NP in Northern California and professor of nursing. I'm here with my PA buddy, my co host, superstar, Mike Sharma. What up, Mike?
I consider myself solidly at star or below level. I don't think I've achieved superstardom just yet. Well, hello everyone. My name is Mike Sharma. I am a practicing emergency medicine and urgent care PA in the Dallas, Texas area, and an adjunct professor of PA studies. Martha, I'm really excited to share that I've discovered the secret to time travel. It's really simple. You switch cell phone services and try to port a cell phone number from one service to another service. And if you're like me, you're lucky enough, you'll look up and all of a sudden, bang, it's 2 hours in the future. Time travel. So now all I have to do is decide whether I use this power for good or evil. I'm leaning mostly good. So
Okay.
excited to be talking with you today. You are a significant upgrade from cell phone tech support hell. So it's great to see you and talk with you.
You are an interesting guy, Mike. That's for sure. All right. So, first, I want to say special thanks to Sergey Motov. Oh my gosh. Dr. Motov on his pain panel with us. Please take a listen. And, Mike, I recently got back from our boot camp in Las Vegas, and it was really great to see a lot of you. All of you. Really great. Thanks for coming out. It was a very enjoyable time. But I had my favorite talks. One of my favorites was Chip Lang's last lecture. I mean, it was pretty powerful. I'm not sure. If you've heard Chip talk before, if you're listening to this podcast, but it's a fantastic lecture. And it was the last lecture of the course. So actually, Mike, we're going to add that as a bonus clip. We're going to include that at the end of this podcast for those of you who may have missed it. And the lecture, you know what it's on? You want to
Yeah,
know?
I was told it was about conscious, no, procedural sedation. Is that correct? Or something similar to
It
that?
it covers a lot of that, but it's mostly on intubation management. And spoiler alert, Chip is the patient. All right. And he definitely talks a lot about his experience with ketamine as well. I mean, really, shoot, you guys, really take a listen. I'm going to give you a preview, so get prepared to be informed. Um, you might get a little weepy. It's a little emotional. Honestly, it's a great review in 30 minutes, and it brings to like Chip's own personal journey um, within his struggle with myasthenia gravis. Really, a trip of a lifetime with ketamine, and it's a must listen, folks. So stay tuned at the end for that.
A trip of a lifetime. I see what you did there, Martha. Very good. Yeah, I was talking to Chip about the talk as well, and he was telling me how he was kind of surprised how affected he was by it. And so I think it's a really interesting way to close out the boot camp, and I'm looking forward to that being a recurring feature for next year's Advanced EM boot camp as well. I'm sad we missed each other, Martha, at Vegas. But you kind of called me at the end there, and you're like, "Hey, I can't make it. Can you do X and Y?" Up front. We have a segment number two that explains why you came late. But for right now, we're going to talk about segment number one. Is that correct?
Yeah, let's not start off talking about me. Let's talk about something else. All right. So, yes, I will share my story as well. But we're going to talk about ocular stroke and retinal artery occlusion for segment one, our wet
And
wound.
yeah, and I have a case study for you on this one.
All right, great, Mike. So, give them the story.
So it comes from the Eastern Mediterranean Health Journal from 2008. Much better than the Western Mediterranean Health Journal, if I say so myself. Anyways, in December 2004, a 28-year-old farmer presented at the clinic complaining of acute loss of vision in the left eye 10 days after he had stopped cigarette smoking. Well, there's the problem right there. Keep smoking cigarettes. Gee whiz. The patient's vision had been good, and he had never had any complaints about his vision before this event. He had a 10-year history of smoking at least 20 cigarettes a day, but no history of diabetes, hypertension, heart disease, or liver disease. Visual examination of the eye itself showed poor light perception by the patient. There is a 3.5 or more relative aferrate pupillary defect, and the tonometry of the eye was 13 millimeters of mercury. When somebody did a fundoscopic exam, they described mild optic papillary redness, retinal paleness, and edema To a vein as well as macular edema. They showed a cherry red spot. And if some of you are kind of like thinking back to your whole person exam, they know exactly what that cherry red spot means. The right visual acuity was 20/20, but in the affected eye, well, we heard about that already. The ophthalmic exam in the unaffected eye was normal. The patient was diagnosed with, spoiler alert, central retinal artery occlusion in that left eye occurring at that 10 days after he had stopped cigarette smoking. And of course, right, a 28-year-old farmer, he's not coming in the day that he loses his vision in his left eye, or even the next day or that night. It's going to be 10 days later, once all the crops have been harvested and things like that. So that adds up for a farmer.
Yeah, so we're not going to keep too much stuff in the dark for this case because we already know what we're talking about here. But I just wanted to reiterate, if you don't know what a cherry red spot is, it's that red tinged region in the center of the macula surrounded by retinal opacification. And there can be various causes for this, but retinal ischemia or retinal infarction are good indicators of the cause of this. So, just to talk a little bit here about central retinal artery occlusion, it's a rare event, and it's at the site of obstruction. Excuse me, the site of obstruction is not usually visible on clinical examination. Therefore, the precise cause is often speculative, right? We're just like, "Ooh, this kind of sounds like that." And it's currently believed that the majority of central retinal artery obstruction or occlusion is caused by thrombus formation. Atherosclerosis can be contributory to the case, although congenital anomalies of the central retinal artery, systemic coagulopathies, inflammation, or low flow states from more proximal arterial disease may often be present and make certain individuals more susceptible. And there are many reports that find an association between smoking and cardiovascular disease and the incidence of retinal emboli.
Smoking, cardiovascular disease risk factors. This sounds like our Las Vegas trip.
Yeah, yeah, yeah. So, truth, your risk factors, they go up. No, this is the long-term smoking use stuff. So, um, but let's go on to what happened with this patient. The patient refused to be hospitalized. Imagine that, and was treated with compression, oral prednisolone, 75 milligrams a day, analgesics, timolol drops, and acetazolamide, 250 milligrams every 6 hours. However, this treatment did not give a beneficial result. And on the third day, he had absolutely zero improvement of his vision. The patient was told to come back for further eye care and evaluation. And on the seventh day of the occlusion, there really was no improvement in that left eye.
Oh man.
I know, bummer.
Well, in this case, the patient who was diagnosed with central retinal artery occlusion was a young person with no history of any systemic disease. So that's kind of weird when I hear about that. It's such a young person. Like, if you're 28 years old, you have not been on this earth long enough to plaque up any arteries. There was a 10-year history of cigarette smoking, but that's in terms of acute smoking exposure, that wasn't there, right? He had not been smoking for a week and a half before the occlusion happened. Of course, they ran all the lab tests, a CBC, liver function tests, renal function tests. All of those were in normal range. Ophthalmologists did Doppler evaluation of the carotid artery. They did an echo of the heart because, right, we think about like AFib, and it's like, why is AFib so bad? It's not because the heart wiggles, but it's because blood can coagulate in the atria, and then when you come out of AFib, the heart yeets that clot out, and that can be yeeted into your toes, into your fingers, into your brain, or into your, carotid artery or anywhere else. But no, they didn't see any sign of atrial fibrillation or other unusual rhythms of the heart. So those were kind of ruled out by the treating clinicians. And then they even looked and they said, well, there's no embolus in the retinal artery. So definitely this was not a kind of thromboembolic event.
Yeah, and people are weird, and medicine and nursing and the whole healthcare world and diagnoses, it's weird, right? So we don't always have the answer. I think that basically the author suggests that in this case, like, we sort of knew what was happening here, but the cause of the occlusion just wasn't determined.
That's bizarre, right? Like we are. I always say that the human body is weirder than we are smart. And so sometimes we don't know why something happened, but at the very least, the clinicians that they figured out that something was happening, and they gave it the good old college try within the restraints of what the patient was willing to do. He didn't want to be hospitalized. He didn't want this or that. So all you can do is kind of meet the patient where they are and give it your best shot.
Yeah. So let's talk about the treatment of central retinal artery occlusion. It can be categorized as conservative. Actually, ocular massage, pharmacological treatments, anterior chamber paracentesis. This is like really high tech stuff, honestly. Or it can be invasive. So, catheterization of the proximal ophthalmic artery through the femoral artery with the infusion of thrombolytic agents. I mean, really fancy stuff. I'm sure our big institutions are doing those things, our Ivy League people and some of these research facilities. But however, really to date, there's no satisfactory therapy available for patients with this disorder. Not many of them do well. And in many cases, any of these therapies that are used aren't really successful. This is turning more and more depressing. But in this patient, after 5 days, they did these medications. Again, no improvement in the visual acuity. Whether he had stayed, whether he had gone home, I mean, it's a bummer.
You never know, right? Yeah, it's funny. You think of like any other thrombotic or embolic event. It's like, well, if you just suck out the embolus, that should fix this. But not in the situation, and apparently not in a lot of situations. That is a real shame.
Right. But I think the authors sort of conclude here in this interesting case study is like this building this understanding of making these diagnoses. And I want to talk a little bit about the eye picture in a second, but meaning what we do with eye complaints and which road diverged in a wood do we travel down. So there are a lot of misconceptions and controversy about the treatment of this and really diagnosing it. But understanding the clinical features and possible treatments is really the important and acting quickly.
I like Robert Frost as well. Well, for ER clinicians, it is important to recognize the following things when you're trying to make this diagnosis, Martha.
Right. So this full eye picture that I like to say, and honestly, took me a while to come up with these types of things over the years, but once you come up with them, it's really good. Make yourself a smart phrase if you need to. And I worked with ophthalmologists very closely when I was in my training. Plastic surgery and ophthalmology were two people I worked with the most. So consider that full eye picture. Ask yourself these questions to narrow down your possible causes of vision loss. So first ask yourself, is it painful or painless vision loss? Okay, because those will give you two different diagnoses channels to go down. Is it an acute or slow onset, right? So is this like I've been losing my vision for 3 years and I need glasses? Or is it acute, in some way that you had some kind of trauma, an orbital blowout? I don't know. Because is there trauma involved, right? We want to know whether it was acute or slow. Trauma. Are they hypertensive, right? So there's so many eye diseases that lead to problematic issues in our hypertensive patient. Is it one eye or is it both eyes? Okay. Like these are basic communication things you're going to tell the ophthalmologist when you talk to them. Are there neurological symptoms? Huge change of clinical diagnosis differential. And do they already wear glasses and they forgot them? Right. What's their medical history? Right. Did they have a retinoblastoma when they were 3 years old? I don't know. Really, all of this stuff may not matter in the long term if you're just dealing with a red, angry eye after a piece of wood flew into it and you have a corneal abrasion. But again, is the eye red and angry or is it soft and quiet? Right. So these are all important things to ask yourself.
The I wear glasses but didn't bring them today drives me absolutely bonkers. But something that you can use to test whether the vision changes, if any vision changes, are related to what's called refractive error, like eyeglass error. This is where that pinhole test comes into play. Some of you may have a fancy pinhole device where they like have a handle and you hold it up to the eye and it's a little hole that the people look through and do their visual acuity through the hole. But in a pinch, you can use a lo-fi method of piece of paper and pencil, and you poke a little hole in the paper. And so what happens there is that this corrects for refractive error. Looking through the pinhole instead of looking through your entire eye vision corrects to some degree for the refractive error. So if they get up there and they're like, "Yeah, I can't really see anything with the eye chart." And then you put that pinhole paper up there and their vision improves, that suggests that there is at least some degree of refractive error going on, and it could just be because they don't have their glasses, versus, "Oh, this is a new change." All right? Part of that also is just asking the person, like, "Okay, you can't see the eye chart at all. Do you feel like your vision is changed?" And they'll tell you like, "Oh yeah, it's totally different," or "No, it's not." I feel like more often than not, people are, well, I think it goes back and forth. I think some people are so grossly unaware that they have decreased visual acuity, like they're shocked to be told, like, "What do you mean I have X vision?" Other folks, they're so sensitive to any change in their visual acuity. They're like, "Oh yeah, I see really blurry." And you put them up on the eye chart and you're like, "You see 20/20 in both eyes." So like
Yeah.
in the end, you don't really know based off of their subjective perception of their vision. And that's why it's so important, of course, to get that visual acuity, right? You get each eye individually, and then you get a both eye vision. This is a vital sign of the eye. It's like someone having shortness of breath, and you don't know how fast they're breathing or what their SpO2 is. This is something. If you have an eye complaint, you have to get a visual acuity, each individual eye, and then both eyes. You check pressure. There's usually some sort of a tonometer, some sort of a handheld device in your ER. Get real comfortable with that. Visual fields are important. What I think is important too, by the way, with checking visual fields, we're not checking for T-Rex vision. Okay, what is T-Rex vision? That's like, the T-Rex is attuned to motion. So as long as we don't move, the T-Rex will pass us by. We're not checking to see if the patient can see magic fingers, like us wiggling our fingers in the periphery of the eye. The more sensitive way to check for visual field integrity is to have counting fingers, counting non-moving fingers. And probably some of you know this, but just to be clear, how I do this is I get in front of the patient and I have them say, "Okay, look at my nose," and I put my hands kind of equidistant, the same distance between their face and my face, and I make sure that I can see my fingers. 'Cause my vision's pretty good. As long as I can see my fingers doing the numbers, then they should be able to see the numbers. And then I'll just go ahead and I'll show them 5 fingers, 2 fingers, a thumb, 3, and I have them count my non-moving fingers at the periphery, upper, middle, and lower. Okay, and that sounds like a mouthful when I describe it that way, but then you just document it as visual fields intact, 2 counting fingers. And that way it's clear what exactly you did in terms of the visual acuity, sorry, the visual fields testing. Going back, one more, 2 more things from history real quick. I like to ask early, do you wear contact lenses? And do you have diabetes? Because right there, from an infectious disease standpoint, both of those things really increase your risk of having weird stuff in the eye. Pseudomonas is the thing I'm mostly worried about, but sometimes you can even have something called acanthamoeba, which is an amoebic infection of the eye, which is really, really hard to get rid of, and it takes eyesight very quickly. But it's important to identify those history risk factors early on, in addition to everything else you mentioned, Martha. And then you make sure you have all that lined up for if and when you consult optho, whether you're calling them or you're just having them read the chart later on. All that stuff should be in your chart, ready to go.
Yeah, so I like to have the patient put 2 little wingies out, their elbows, put them out to their side at a 90-degree angle, and that's the distance in which I do the hands, and then I
Oh,
put one hand straight ahead, and that's how far away I am from their face, and that's usually pretty good. That's an ophthalmology, um, trick, but
I like that.
yeah, I like it too. I like it a lot. Alright, so the most common symptom, let's move forward here, of retinal artery occlusion is sudden painless vision loss, right? So we talked about the things that we want to know. It's sudden, it's painless, and that's the cause of the vision loss. Or excuse me, that's a symptom with the vision loss. That makes sense, right? So you're going to lose vision um, in one part of the eye or all of the eye. And in some cases, the vision may have been lost in the past, but come back again due to these blood clots. So it can be kind of transient at times. Maybe they actually had this happen 3 days ago and then it got worse and happened again. So again, we check the visual acuity. You want to make sure that you have both eyes together as well as individually. And really, that's how the ophthalmologists determine how good the prognosis is how bad their visual acuity is. So don't underestimate it. When they don't call them, okay, without this information, or you're gonna look like an idiot. So stop doing that. And keep in mind that central retinal artery occlusion can lead to permanent loss of eyesight in the affected eye. Boom.
Yeah, just like this person in the case study, right? You want to give this person the best possible chance of recovering the eyesight. And so this is one of those things where you are going to consult ophthalmology that day or get them to an ER that can consult ophthalmology. Maybe a transfer is required, especially if you're in an urgent care clinic. Okay. Well, this is something again where risk factors are things like cardiovascular disease, things like that. Not a thing that you're going to see in a pediatric emergency department setting. Okay, and speaking of, we are just days away from our Mastering Pediatric Emergencies course that is going to be. Well, by the time you listen to this, it may already have been September 10th through 12th in Las Vegas, Nevada. Now, good news, this is the second iteration of this course. If you're like, oh man, I just missed it, I really need to get smart on PED stuff, never fear. We have the streaming version of this as well, where you can get CME and CE. So you can sign on to our website for the Center for Medical Education. That is going to be www.ccme.org, www.ccme.org. You're going to have abilities to get the streaming versions of the Mastering Pediatric Emergencies course. There's new courses out there, airway course, emergency EKG interpretation. I'm super excited about that. Dr. Levitan is kind of like made a huge name for himself in terms of airway management and airway techniques. And we have a new course from him I'm excited to listen to. And of course, we have the emergency medicine boot camp course, the original OG emergency medicine boot camp course. You can get that streaming if you can't make it out to us for the December course, Martha. When is that going to be?
The 4th through the 7th of December. Yes. Oh, sorry. That's that's the main camp. Oh, I forgot to mention we have all these other workshops. We've got the ultrasound workshop December 2nd, 3rd, and we also have the procedures workshop that's on the 3rd, as well as the pharmacology workshop. So you can pick and choose what you want depending on how much time you want to commit to doing stuff. Also, if you want to hang out and sign up for these courses and come join us, why don't you go to this link, all right? You go to it's not www. You just type in your browser, okay, the https semicolon backslash bit.ly backslash embc dash las for dash Vegas. So it's a bit.ly uh link. If you don't know about those, they're short little great links that take you to special pages, and you might find yourself a surprise there if you go. So bit.ly backslash embc dash las dash vegas Vegas. Did I say that right, Mike?
Yeah, you did. Yeah, this is a cool thing we're starting. We really want to meet people who listen to the two of you, get your feedback on the podcast, and continue to be tailoring it towards what you need out there as an emergency medicine practitioner. So please do if you when you come to Las Vegas and hang out and learn from people like me and Martha and Chip Lang and nurse practitioner Michael Gooch, who's doing the pharmacology workshop. Everybody, all the main instructors out there, please do sign up through this bit.ly link, bit.ly slash EMBC dash LAS dash Vegas. We're going to put that in our show notes just so it's clear you are flagged as a two-view connoisseur and that we'll know you're coming and we can kind of link up with you and do some cool stuff while you're in Vegas. Okay, so that will be in our show notes. Like I mentioned, go to our show notes for that. That is at twoview.fireside.fm. If you remember nothing else about all these links we're throwing at you fast and furious, twoview.fireside.fm. That's the number twoview.fireside.fm. You'll see information about everything we're talking about today, a reminder about the Bitly link, and just everything you need to get more involved and get more of your knowledge on.
All right. I'm getting hungry, Mike. I'm getting a little hangry. So I want to move forward to segment number two. This is our
Okay.
dry scan. Okay. Segment two, we are going to talk about something a little, we're going to penetrate a little deeper into some other topics here. So if you're an avid listener of the show, you know that we recently in the last year, me personally had an episode of ventricular tachycardia, which I think turned out to be SVT with aberrancy. But hey, that's what Amal thought. Amal Mattu, my favorite cardiologist. I'm not holding him to that diagnosis because he wasn't there. But anyway, regardless of the actual diagnosis, I want to talk a little bit about the procedure of cardiac ablation and what patients may arrive with postoperatively within weeks or months after their procedure. Sure, sure. They're talking to their cardiologist. Of course, they're trying to get in the office, but hey, it might be 2 a.m. So we know that cardiac ablation comes with risks and complications as well as pain, bleeding. And Mike will mention a few other here in a second, but it also comes with the risk of DVT or pseudoaneurysm.
Yeah, we might think like, hey, this is not my bag, baby. This is an EP's bag to do a cardiac ablation. But yes, exactly right. If they have a complication, they don't just go knocking on the EP's door at 11 p.m. at night. They come to the ER, and we have to know, hey, why do I call the EP, or what can I handle on my own? So let's dive in here. In terms of risks of adverse effects, it really depends on the kind of ablation and why it was done. Ideally, this patient is coming to the hospital where their EP is credentialed and can see patients, but we all know that doesn't happen every single time. So, ideally, you can just kind of look back into the records there from your own hospital system, but sometimes you don't have that. So, you may have to do a little history taking, figure out, of course, who it was that performed it, where it was it considered a success or not? Are they on any sort of medications? Of course, anything with kind of anticoagulation properties may cause complications. Speaking of complications, some of the things we worry about here are you know, DVTs in the legs or PEs in the lungs. A big risk factor for thromboembolic events is that, as we recall from Virchow's triad, endothelial damage. You get in there and you nick up the insides of the blood vessels, we are at risk for blood clots. And sure enough, that's happening when we're doing a cardiac ablation. Bleeding or infection where the catheter was placed. There can be some, usually 8 French is kind of the size of the catheter. That can, of course, vary based on the size of the person. So it just kind of depends. The blood vessels can be damaged accidentally more than needed. Heart valves can be damaged more than needed. So, God forbid you hear a new murmur. Maybe there's going to be a new arrhythmia, right? Ideally, we're trying to suppress arrhythmia with this cardiac ablation, but sometimes it goes the other way. And now we have a new arrhythmia going on. Maybe there's bradycardia. God forbid there is a stroke or even a myocardial infarction, but that can happen. Maybe there can be some sort of a pulmonary vein stenosis, a narrowing of the veins that carry the blood between the lungs and the heart. And lastly, with a lot of ablations, there is contrast used. And so, I know contrast-induced nephropathy is not a very common thing, but that is something that can happen as well. You could have some nephropathy, maybe not from the contrast itself, but maybe just from any sort of time where maybe there was some perfusion to the kidneys as a result of the procedure. Of course, worst case scenario, people can die. People can die from this. You ablate the wrong thing or what have you, and it can cause catastrophe.
All right. Yeah. So thanks for reminding me. It can also cause death. But what exactly is a pseudoaneurysm and how do we know if we have one? All right. Well, so first of all, when this patient comes in, ask about their history and, you know, get a good picture here of what's going on. But during the cardiac cath procedure, a catheter, as we talked about, it goes in there. It's usually in the groin. Sometimes it's in the wrist. Sometimes it's in both groins. And it's guided up to the heart, right? And then certainly there could be some blood leaking. It gathers outside of the artery. So this is leaking and pooling, basically, not clotting and stopping. And then that pseudoaneurysm can form. And so a pseudoaneurysm basically occurs when the blood vessel wall is injured, and that blood and the leaking kind of collects around that surrounding tissue. And in a true aneurysm, the vessel wall weakens and then bulges. So a little different here. And sometimes the actual aneurysm, right, causes this blood filled sac, and then boom, that explodes. But in the pseudo aneurysm, the vessel wall is really injured and it's leaking. So we all know the workup and diagnosis treatment for DVT, whether it's postoperatively or from another cause. But I would specifically like to talk about the pseudoaneurysm part of this because it's definitely a complication of cardiac catheterization.
Right, you kind of rattled off a couple reasons why you might get a pseudoaneurysm. You mentioned rupture of an aneurysm. You mentioned iatrogenic cause. We could do this to the patient, but also infection to the local area could also cause there to be this kind of unusual blood flow and collection in the surrounding tissue next to the blood vessel wall.
Yeah. And so these can actually, the pseudoaneurysms of the femoral artery, which is what they were looking for in me, due to cardiac catheterization, may go undetected, not cause any complications or symptoms. Sometimes people have mild swelling in the thigh area and the groin area, but that may not be till days or even weeks. And in rare occasions, months after the procedure. So in my case, I had this ongoing groin pain a few months after my procedure, and I took my handheld ultrasound and I went to take a look. I pulled my pants down, I put that thing right in my groin. And actually, it's really hard to do in both axes because I'm doing it myself, so it's really hard to kinda get in there. You can only do it up to a certain angle. And so I saw something that I thought looked concerning, but, I couldn't tell because I really couldn't get the right angle to investigate. So I went and I got a formal ultrasound in my local ED.
That's how a lot of great stories begin. I pulled my pants down and I put my thing right in my groin. But anyway, so thankfully, this was also another good story here. We had a good outcome from this one. You had someone do a formal ultrasound so they can look, and you were cleared, thankfully, of this pseudoaneurysm. What else usually happens when somebody has a concerning, I guess, symptom picture for a pseudoaneurysm? Aneurysm? Is there anything other beyond the ultrasound that is performed to work this up?
I love that question because, everyone's like, let's get labs. Let's get, yeah, hey, maybe we need a chest x-ray. Like, but I don't want any of that stuff. Just get the ultrasound. Okay. Just get the ultrasound. Stop ordering tests that we don't need. So sure, like let's say I did have a pseudoaneurysm. You get the blood test after that. But if there's no other reason to get blood tests, don't get them. And you certainly don't need any additional images and you don't need to go right to a CT or runoff studies. I mean, come on, what's your exam showing you? So certainly you want to ask the patient, do they have a history of blood clots or aneurysms in general? Which I did, by the way, because I had a little aneurysm. Well, I still do in my left ICA. But of course, there are the idiopathic reasons for pseudoaneurysm. Certainly you can get them for no reason whatsoever. And, and you know, for whatever reason, people who have aneurysms in their family, their offspring also has aneurysms. So worth noting, my mother had an aortic aneurysm. My father had died from an aneurysm in his brain, and I definitely felt like I was at bigger risk. So I also ask all my patients if they're on blood thinners, but again, that doesn't even necessarily make me order a blood test. Maybe I get an INR. It really depends.
Yeah, quick kind of side story here. I had somebody come in and they had some unusual bruising going on, and they were worried because the bruising was spreading, but really it was just kind of tracking down. Like we know, like bruising, if you have bruising in a proximal part of the body, gravity does what gravity does. It pulls that bruising down to the lower extremity, and so like they were kind of concerned, but they already got it in an X-ray in another place. They didn't see any sort of weird bony stuff. And so in terms of, like, ordering, because like, like, so, okay, I have a patient who comes into the ER for bruising. It's like, well, do I have to, like, very localized bruising. Do I have to order all these, like, coagulation studies and stuff like that? And so we kinda talked about it, and I asked some questions, right? Because where do we go? How do we decide what do we order? You ask some good questions. And so my questions were, okay, you had this bruising that happened in one part of your body. Do you feel like you're having easy bleeding in other places? Are you having unusual vaginal bleeding, rectal bleeding? When you brush your teeth recently, do you have bleeding in your gums? And that was no, no, no from this person. Like, okay, dope. And then I asked about other things, and they said, no, I don't really have those things. No family history. I'm not on any sort of regular medications. And so I made the decision, isolated bruising in one part of the body. I don't think we have to keep you here and run you up all the way to the flagpole because in the end, this bruising is either going to go away and you never have it again, or you're going to have more bruising. And in the end, you have to follow up with a family doctor. There are way more coagulation studies that we're not going to order in the ER that would be important for somebody who has recurrent bruising. So in the end, I made the call. I'm not going to order a bunch of stuff for your isolated bruising. Anyways, that kind of goes back to like, what do we order when somebody comes in with this like question mark pseudoaneurysm or not? And there's kind of two schools of thought. Like maybe you're more conservative in this situation, like I was, where it's like I'm not going to order a bunch of tests just to order a bunch of tests. Or the other one is I'm going to order all the things in addition to the ultrasound because I just want everything to come back at the same time. And then I can pull the trigger completely on all the information that I need.
Sure,
So,
that's fine. That's fine. That's fine. I won't argue with you. But
well,
just
no, it's not even me contradicting you. I'm agreeing that I don't think we have to order all these things. In the end, though, it's going to come down to the patient's history, your examination, and in the end, kind of what you guys decide together. Is it terrible to order a bunch of, blood tests? Not necessarily. It's hard to even stub your toe and come to the ER and not get, a CBC, a CMP, and three different X-rays. But sometimes I want to advise you that maybe it's not warranted.
yeah. All right. Well, let's get into the test that is useful here. Very useful. And that is the duplex ultrasonography for superficial femoral pseudoaneurysm. Okay, it's the gold standard for the diagnosis. It can evaluate the size, the anatomy, the origin of the pseudoaneurysm. Where is this thing at? And studies have shown, right in our literature, that ultrasound it has a sensitivity of 100%. So you don't need a CT. Get the ultrasound first, and really, you need to specify in your order what you're looking for. Don't just write leg pain. Be very specific what you want. Post cardiac catheterization patient looking for pseudoaneurysm, query, blood clot. List all the things that you might consider putting in there so your radiologist knows. And then the technique is really this sonographic evaluation of the arterial anatomy of whatever the extremity is. And they use the combination of the grayscale and the color flow and the spectral Doppler waveform analysis, ABI pressures, yada, yada, yada. Sometimes can be tamed. But what I find is interesting is depending on the tech, they may not do those pressures. So you might want to specify that as well. And you could do them yourself if you want. I mean, it's 1975 somewhere. You said we're time traveling. So, in the spectrum of time jumping, typically the treatments, if the pseudoaneurysm is wider than 2 centimeters, that's about 3/4 of an inch, you consult vascular surgery pretty quickly. And then they might do the following three things that day.
Yeah, there are some options here. So one is you can do an ultrasound guided compression repair. So of course the ultrasound shows that pseudoaneurysm, and so basically you can use the ultrasound wand or another device to kind of push on the pseudoaneurysm. You kind of like you an ultrasound guided compression. And so the idea there is we're kind of just like breaking up that hematoma, that pseudoaneurysm, and kind of dispersing that collected blood. So that's one option. Second option is this an ultrasound guided medicine delivery. So maybe what we do is instead of just kind of like physically dispersing the pseudoaneurysm, they'll inject a medicine like thrombin or something else into the pseudoaneurysm. Okay, and so you're again using the ultrasound to make sure your needle is really just bullseyeing that pseudoaneurysm, and then you inject thrombin. As we know, thrombin has to do with clotting, and so it takes that pseudoaneurysm and it kind of like firms it up, make sure it doesn't grow any further or rupture. Third option is surgery, is going in there, and you may have to go in there and more directly correct the pseudoaneurysm. Which one is chosen? That's of course going to be up to the vascular surgeon.
Yep. All right. So if you've had any type of catheter procedure and noticed some tenderness or swelling in the area, then doing this workup is a must.
Yeah, we were, I remember you calling me about this, and you were kind of like going back and forth to a certain degree of like, what do I do here? Like, do I even go and get this checked out? Is it just leg pain? I don't have to worry about this. I should just go in. But of course, you know that having had a procedure there, you're at much higher risk for a weird something
Yeah.
going on. You had this
Yeah, yeah.
penetrating injury, right?
Right.
And so that's what we tell your patients too. It's like, I wouldn't suspect this if you hadn't had this trauma, but because you had this trauma, we have to dig a little more. So speaking of digging a little more, what do they find with you? Good news we talked
Yeah,
about.
yeah, yeah. So at the end of my evaluation and my treatment, I didn't have any labs done. I just got this special ultrasound ordered and completed. And I ended up having a normal ultrasound study. And I was very happy with this. My results, what you are looking for on the report, are the following things. So you want multiphasic waveforms in the external iliac artery through the distal superficial femoral artery, or SFA. No pseudoaneurysm, no dissection or stenosis identified, no hematoma. External iliac vein, common femoral vein, popliteal vein, and infrapopliteal vein show no evidence of DVT. So, really important that all of those things I just said are in your report. If they don't comment on the distal part of the leg or the iliac veins, any of that stuff, you got to call. Look at the images yourself also, right? You can see, is there blood flow or is there not? Is there a big pseudoaneurysm or is there not, right? So, um, I did have some lymph node swelling. I don't know why, but I did. So that may have been from that it hurt. Maybe it was from something I pulled or an exercise or who knows what happened. But yeah, it everything is great. Sorry I was late, but look at us now. Look at us thriving, talking about stuff.
No doubt it was from all those plates you're pushing with your big squats and your deadlifts at the gym there.
Yeah, right. Yeah. All right, Mike, let's wrap this up because I'm telling you, I'm really hungry. Okay. I need food. I was going to point out a couple things about pseudoaneurysm. Just a few. Okay. It's not very common. It's pretty rare. Small percentages, but still put it on your radar. And really, just ordering that right ultrasound test, super important. I'm just scrolling through some of these. And again, understanding that even surgery for these may carry an increased risk. So nobody's making any decisions at 2 a.m. on this, but they will at 6 a.m. So make sure you get that ultrasound wrapped up and consult to surgery before shift change if you're working the night shift. So moving on to segment 3, which we're gonna let you spin off on, Mike.
Yeah, so we're gonna talk about some legal stuff real quick. We'll do some legal stuff. We'll wrap the podcast up, and then we'll put in Chips
Oh yeah, I
talk
forgot.
after
Forgot about
our,
that.
our goodbyes, right? So yeah, so my side of things, we talking about some legal stuff, and I want to share a recent experience I had with the law. And no, it had nothing to do with me speeding or holding something for someone. I was recently subpoenaed to testify as a witness for medical care that I provided for someone. It wasn't a malpractice case. Don't get it. If you're on my insurance company, my malpractice insurance here, don't worry, it has nothing to do with that. Okay. My medical care wasn't on trial, but the lawyers did want more information about the care I provided to just shed lights on the events that the case was about. And I know I'm talking kind of tangentially here, but right now I think it's important that I do that because the case isn't yet resolved. So I'll be kind of just more talking more broadly about it. Some things in case you happen to get subpoenaed as a witness. Some things looking back on the event that I was told, but maybe it's just nice to hear it from me, to hear it from your friendly neighborhood Mike Sharma, and it sounds different than coming from your legal department here. So number one, you should advise the legal department of the company that you were working for at the time. For me, it was actually right now I work full time at a different company, and so I've actually number one figured out like, okay, wait, where was I working? Okay, got it. Who do I even contact for that? Because I'm not full time there anymore. So I had to get that information, call the legal department. They responded very quickly and they said, "Hey, this is very reassuring." Again, reminder: you have to go. That's the second thing. You have to go to this thing. You're not going as like an expert witness. This is like not an optional thing to do. You are being subpoenaed often by the state or by the jurisdiction of who's subpoenaing you. And so if you don't obey this subpoena, this legal order, you could face penalties for that. My legal department did have some nice tips though, as far as things I should and shouldn't do. So that was very helpful, and I use those to great effect. Next thing, when you're in the witness box, you might feel like you are on trial, that your care is being questioned. You're not. So, hopefully, walking into the occasion, just remind yourself, I'm not on trial. I'm just being asked questions about the care that I provided. Next point. When lawyers start doing lawyery stuff and asking you very kind of directional questions, because there's a lot of this, like they're asking you yes or no questions. And sometimes you can ask a question that is a yes or no question that kind of may feel like you're being entrapped. Okay. Um, and it's like a question like, you know, John, does your coworker know that you beat your spouse? Yes or no. It's like, wait a minute, that's not a yes or no question. I don't beat my spouse, right? So like sometimes you have to go, I can't really answer that question in the context of a yes or no. Okay. So it's, if it's a yes or no question, you can respond to appropriately, just say yes or no, and maybe just leave it at that, especially if it's a weird question. If you don't think you can appropriately answer the question as a yes or no, then you can just say that. You can say, I don't feel like I can appropriately answer that question as a yes or no question. If you start getting a little too explaining, like I often did, the lawyer may object and you might have to stop talking and do something else. Okay. Last thing, I suppose, second to last thing is this. As much as you may have been subpoenaed by the defense or the plaintiff, in the end, if you're going as a witness, all you're doing is you're there to describe your care as accurately as possible. Sometimes the law and medicine and nursing, their intents, their interests are opposed or at least not perfectly aligned. So this hopefully frees you when you think about it in this way. All I'm here to do is describe my care. This frees you not to worry about, am I helping or hurting somebody else? All you're doing is being, as Ken Millen often says, on team patient, advocating for the patient and describing the excellent care that you provided.
All right. Those are good tips. Mike, you look like you're frozen, but you're not.
I'm here. Do you want to talk about your thing or do you want to save that one for next time?
Well, I really like your tips. I think they're good, but I do want to look at something from another angle and kind of just put this out there that if there's anybody in here that wants to do some expert witness or chart reviewing, and you want to get started on this, Mike and I have both done this on the other end of the arena here. And so if you want to get started, people are like, how do I get started? Well, you got to know somebody, right? You got to know a lawyer or somebody else that's been doing it, and you need to get referred and you need to have experience. Make sure you have at least 5 years. I mean, geez, 10 years experience would be best. And it needs to be clinical bedside experience. So experts are called this because they have experience. Experts have experience. So then write 1 to 2 paragraphs as to why you're an expert. If you're struggling with this part, I would reconsider your plan. Okay. Definitely reconsider. And then, list your schools, your degrees, your publications, years in practice, types of practice, any awards, position status, include all that stuff. And then you can also, talk about once you've done some case review, like how many cases have you done? Because they're going to ask you, how many times have you done this? Is this your first time? All the things. So then put together your fee schedule. This may be state or work dependent, but generally speaking, $200 to $300 an hour for reviewing material is not unreasonable, especially when you are really truly experienced and an expert. You're reviewing charts, cases, complaints, you sort out the medical lingo, you give a 1 to 2 page summary in what's called a preliminary report. And then you can use evidence-based practice to support your reasoning for or against the issue. But in general, I save that for the deposition. I got enough stuff in the bank that I can say, oh man, this sounds really bad. Or, oh man, this sounds great. Like, why are they bothering this person? So again, your deposition court time is a little bit different. And the pay that you're asking for your deposition and court time is different. I tend to do 350 or more an hour, depending on what you're doing. And you should always have a retainer. And remember, you don't have to be a lawyer to do any of this. I most certainly am not a lawyer, and it's just my opinion. And none of this is admissible in court. So don't quote me. The California BRN is currently hiring, so check that out. You can be an expert witness for the nurses if you like. And I'll post the link there. You know, everybody always gives me a hard time when I give out my email. It's not a problem if you email me. Email me, M-A-R, 79 at georgetown.edu. If you're really stuck. And then clients will come to you after you have a few cases, and then really just bill on the lower side at first because you want repeat customers, and also you want the experience. So yeah, I'm not going to write your fee schedule for you. Don't copy mine verbatim, and also I'm not going to get you a job. So if you have other questions though, feel free to write me, Mike.
Yeah, so you have a link that we're going to put in the show notes again to view.fireside.fm. That's the number two, view.fireside.fm. And we'll have some links here. Martha's got her own link for the Board of Nursing for California. I've got a link for PAs out there for the Academy of Physician Associates in Legal Medicine, also known as APOM. And I am a proud APOM member because of my interest in the medical legal side of things. And when I did some expert witness testimony, or at least expert witness work previously, I used their resources on their website to kind of learn more about kind of how I should approach this. And so that was very helpful. The lawyer I worked with was very appreciative, and he was like, "This is your first time doing this?" I was like, "Yeah, it is." Thanks to the help of APOM, but also of you, Martha. I consulted you and some other folks as well to make sure I did a good job, and so that was super helpful there.
Cool. Rock on. Love it. Let's peace out now.
Okay, we've got our two view trivia question here. Do you want to answer the or ask the question?
Oh shoot, I forgot about that. No, you do it. You do it.
Okay, great. Well, you've got it right here, right? We haven't done this one yet. Okay, so
Yes.
I'll go and do it. All right. So we were talking about central retinal artery occlusion early on. We don't patch a lot of things in the emergency department. However, we're going to talk about patches right now. About how long does it take for your eye to fully adjust to the dark? And what notorious group of people wore eye patches to assist with this adjustment? So it is our two view trivia question. You're going to need to answer two parts of that question, and you're going to send us your two-part answer in addition to anyone you want to give a shout out to if you win, other feedback or comments of the episode, to our email address. That is the number two viewcast@gmail.com. That's the number two viewcast@gmail.com. Well, thanks for listening, friends. But we are not done yet. We're going to wrap it up here, and then we're going to have some, some awesome theme music, and then we're going to splice in Chip's talk from the most recent Advanced Emergency Medicine Bootcamp. I've been really listening or looking forward to listening to this. I haven't done it yet, and so when it comes out, we'll all be listening together. So look for that at the end of this episode. For more information on the original Emergency Medicine Bootcamp, the Advanced Emergency Medicine Bootcamp, the Emergency Medicine and Acute Care course, by the way, locations and dates have been released. We're going to put a website you can go to in our website so you can kind of get the first crack at registering for these courses. It's our VIP list. Any of those courses, they're available at the Center for Medical Education website. That's www.ccme.org, www.ccme.org. Thank you for listening and attending this episode of The Two View. You can subscribe and rate us on Apple iTunes Podcast, Spotify, and YouTube Music. Search for Two View Emergency. That's the number Two View Emergency. It'll come right up. Ratings help us climb the charts so that other clinicians will get some Two View goodness like you did today. If you like YouTube and want to see the video blog, Martha's flowers around her microphone get bigger and bigger with every episode. It's really interesting. I'm wearing a fetching floral print shirt my wife got me. Thanks, Monica. You can see all those things at our website. That is ccmelive.org, or you can go to Center for Medical Education on YouTube and catch the video version. Don't forget that website. We can all say it together at this point. I've been saying it so many times today. 2view.fireside.fm, where you can get all of the show notes. Our audio and video engineers are Ricky Bucata and Dave Pett. Show notes are by Meg Dipple.
All right. That's it, guys. Thanks for tuning in. Friends in EM, share this podcast with a friend. Share your thoughts via email. And thanks for sharing your time with us today at the Two View. Have a good day and a great shift.
And take it away, Chip Lang.
Like I said, one last thing we're going to talk about is post-intubation management. And this has been a nice little progression for me, right? We got to talk about procedural sedation, we talked about airway adjuncts, we talked about RSI. Now we've done those things. Now what do we do? So there obviously are objectives as far as what we're going to talk about here. We're going to lay that out. The first thing I want to talk about is having a checklist. You are never wrong having a checklist, okay? It is extremely important to use checklists when you can. You can only store so much of your brain at one time. I have a book that I use called the Resuscitation Crisis Manual. And what I use that for is it basically is set up as a quick checklist where I run through the things that I need to do that I need to make sure I don't miss, and the other page has some additional details that I might use when I need it. A checklist is not a bad thing. Make sure that I don't miss stuff. Same thing here. This is a nice little checklist you are welcome to use. This has all the stuff that I think about when I'm thinking about taking care of an airway. And as you can see, I try to put this in as much of an order as possible as far as like think about these things and think about the next part. But again, even though this is the last one that I put, achieve adequate analgesia and sedation, it is the first thing I want you to think of, because this is something that's very, very easy to miss. I already talked about this a little bit with the RSI talk, but I want to go into this more detail now. It's critical that you identify this, because this really can cause lasting trauma, not just to the patient, but also the family. Family being in a space where they see this going on, where they know their loved one's in pain and they can't do anything about it is very upsetting. And so what can we do? What are the signs? Well, if they have change in vital signs, they're hypertensive, they're tachycardic, those are some good signs. Also, if they're agitated, they're restless, they're moving around, that's another one. So, if they're biting or trying to grab at the tube, you probably need to add a little more medicine on there. We talked about if they have some irregularity in their breathing, or they seem to be fighting with the vent, those frequent vent alarms, the vent alarms are warnings, okay? When a vent alarm goes off, you need to pay attention to that. That's one thing that annoys me significantly in my emergency department is when a vent goes off and no one goes to check it. If no one's going to check it, I will be the one to check it, and I will be kind of upset the whole way I'm going there, because like someone else should be also racing towards this to figure out what's going on. You'll have the different levels of alarms, and I have little ways of remembering them, like, uh-oh. Like, if you hear that one, it's like, hey, that's a little warning, kind of pay attention to that, versus I have a series of expletives for the one that like ramps up real quick, because that's what should be going on in your head too, is that like, oh no, something else is going on. If they're not paralyzed, you might notice some facial changes. So they might be grimacing, they're sweating, their muscle tone changes, they get real tense, right? But if you have someone who's paralyzed, the only thing that you might notice are tears. So tears are something that you really can miss very easily, but you want to look for. You gotta swap my pack. All right, break here. Oh, wait, I think it was screwed loose. Right, exactly, yeah. Okay, so again, we need to think about analgesia, sedation, right? You need to recognize this. Again, tears may be sometimes the only thing you notice. The tachycardia may not always be present, right? If they're on beta blockers, for example, they may not be able to get tachycardic. Tachypnea, if you are using certain vent settings, that might not be possible. Especially if they're paralyzed, they're not going to be able to work against the vent. You paralyzed them. So tears may be the only thing that you notice. And that's something to really, really think about, because the hypertension and the tachycardia may not always show up. You need to have this ready before you intubate. I know we talked about this already. I'm going to hit it again because it is so important. If there is anything that you can take away from this lecture, it is to actually have your sedation, your analgesia, ready before you intubate. Not just, oh, this is what we're going to get. Have it in the room. Have it ready to go. Okay? There's no reason not to do this. Take that moment, make sure it's there. There are lots of different options that you have. Opioids, ketamine, propofol, benzodiazepines, dexmedetomidine if you have it. That's kind of a fun one. But I have on there, you have tables in your book I went to list all the kind of analgesia options as well as all the sedative options that are kind of like the big ones. This comes from a table in the notes here, but I wanted to pick out just a couple of each. So fentanyl, it's a very common one to get in a drip form, very easy to do, very easy to bolus as well. Like I talked about, I'm not shy to give them a couple hundred mics of fentanyl. It's usually pretty cardiac stable, pretty safe there with it, especially if you're not slamming it at home, you kind of push it appropriately. But also, what's the worst that they have? If they stop breathing? Cool, I'm taking care of that for them. So that's not a problem. But ketamine, love the use of ketamine here. But it's also really important to make sure that when you're doing the ketamine here, that again, remember how people go down is how they come up amplified. Not necessarily that you're expecting ketamine to wear off of someone, but it needs to be a bridge to something more. Most of the time, we aren't going to keep people for longer term on ketamine, probably while they're in the emergency department or they're being transported to another area. But once they're usually up in the ICU, they don't usually stay on ketamine. They're usually being transferred to something else for pain control like fentanyl. And for the sedatives, it's usually going to be something like this, midazolam, propofol. Those are great options. Okay, we talked about a lot of the pros to them. I really, really like to use propofol in this case because of the quick on-off, right? If I have someone that I want to assess, I can turn off the propofol or turn it down, and I can make them comfortable. So what is a comfortable range? We've probably all seen this before, the RAS, right? Your RAS and trying to figure out where you want to go. There is a perfect stage of what you kind of look for there. My thing is I want them to be arousable to a certain degree where they're still very comfortable. And I have a whole separate story I could give someday about like a patient that I intubated like back to back to back kind of thing. And one of them was this crashing asthmatic. And the coolest thing, I managed to perfectly handle her sedation because I wanted her to breathe without having the risk of like too much auto peep and stuff like that. So I could wake her up just by talking to her, and she would nod, she would shake her head, and I asked her, I'm like, are you in any pain right now? And between the fentanyl and the propofol, she was good. Like, you can have someone like that. We are so busy in the ED, we're like, no, I don't want them awake at all. So we give them like way too much and we snow them. That's not always the best thing, especially if you're in a spot where you might be boarding patients for a little bit. It can be deleterious. It's not the best feeling in the world. So vent settings. Again, this could be its own dedicated talk. So the real quick here is that there are some great options. There's like Dominating the Vent with Scott Weingart with MCRIT. He's got a 2-part thing. It's about an hour's worth of talk. But the big takeaway that I'm going to just pull from it, because it's definitely its own thing to check out. Again, it's called Dominating the Vent, Part 1 and Part 2. You can find it on YouTube and other places. But assist control. Assist control is fantastic because it is pretty user-friendly. And then you have to break it down to one of two modes. Is it injury or obstructive? Obstructive is, again, our crashing asthma or crashing COPD patient. Pretty much everyone else falls into the injury category. So we're thinking about pneumonia, it can be trauma, stuff like that. And one thing to do is if you have RTs around, hopefully you do, they can be your friends with this. It's worth talking to them and setting things up. And I have a very good relationship with our respiratory therapists, so much so that I usually change and move the vents and do the stuff that I want to, and then I update them as far as what we're doing there. Not everyone has that relationship. Most of the physicians I work with, like, if they even look at it funny, they get yelled at. But that's because we spend a lot of time talking about what they want, how we can do it, how it meets my goals too. But they can really be your friends here. I have this slide for the injury strategy. So again, this is 95% of your patients in a lot of cases, right? This is where you're going to do most of them. So I have it broken down by mode, tidal volume, the inspiratory flow rate, the respiratory rate, and the FiO2 and PEEP. Keep in mind, 6 to 8 cc's per kg is based on predicted body weight or ideal body weight, not their actual weight. Just because someone became 300 kilograms does not mean that their lungs changed in size, okay? 300 would be massive. 200, we'll say that. But they didn't change there. Base it off that 70 or 80 kilogram, right? Inspiratory flow rate. We want it to go in quickly. It's more for comfort than anything else. Usually 60, 80 is good. Respiratory rate. Usually it's safe to set at 18. There are exceptions. So if we're talking about certain types of overdoses with acidosis and stuff like that, like your aspirin overdose, for example, we tend to go much, much higher. But the FiO2 and PEEP, Start at 100% FiO2. Start with a PEEP of anywhere between 0 and 5. I'm usually a fan of 5 because I want to make sure I'm actually driving stuff in there in most patients. Wait about 5 minutes at that. I will draw an ABG in this case because, again, they're sedated and stuff like that. This makes things much more comfortable for everyone involved. And then I'm going to titrate based on that. And so usually I'm going to drop my FiO2 starting usually from that 100 maybe down to 60 or 50 or however the ABG looks, and then affecting the PEEP. This is an art. This takes a little bit of practice and time, but this is one of those things that you can make someone's life much easier, and you can really change their course if you do this correctly. Pressure alarms. Again, there's lots of them. There's different things. But one of the biggest ones is that the pressure alarm is sometimes a huge annoyance because some people, especially if you're talking about like pneumonia and people who are kind of in that ARDS picture there, pressure is constantly freaking out. But if you put a plateau pressure, which usually there's going to be a way on the vent, and it depends model to model, so it's definitely something you want to check. But you can hold this plateau pressure. And you can check, and if it's over 30, hey, you probably should decrease your tidal volume. If it's under 25, maybe you can increase it. But there are different ways of how to find that. And there's this ARDSnet protocol. I have, for an example of the ARDSnet, where we focus on lower PEEP and higher FiO2. Down here, again, as another reference. Obstructive strategy, a lot of the same. Even higher inspiratory flow rate because we're trying to increase the expiratory time, right? We're trying to breathe off as much CO2 as possible. The respiratory rate's a little bit different. FiO2, PEEP, the main thing is we have usually 0 PEEP or ZEEP, and that's to help with any of the like air trapping that can occur because it's more likely to occur in these patients. Speaking of air trapping, so this is a very real problem. You probably have heard of the DOPE mnemonic before. I see some nods for that. There's what's called, I like to add in DOPEs. I add in the S for stacked breaths. So DOPEs, if you're not familiar with it, D is for displacement, O obstruction, P pneumothorax, E equipment failure, S stacked breaths. This is what I want to think about. If I have someone who's starting to go downhill on the ventilator, these are the 5 things I need to think about, but I can make this simplified. I can make this pretty straightforward. And what I'm looking at is that, okay, if it's displacement or obstruction, I need to replace or exchange the tube. If it's a pneumothorax, I can help see that on ultrasound or chest x-ray, needle decompress, finger thoracostomy, whatever floats your boat. You know, you pick something, you stick with it. I'm a big fan of finger thoracostomy because it happens quick. And if you don't know what I'm talking about there, it's fantastic. You just take a scalpel, you stick your finger in and go to town. Open that up, and then you can transition to a chest tube. It already sets you up for the chest tube. It's fantastic. It's just like a nice little intermediary. If you do not have chest x-ray or ultrasound, because I understand some of you are in that situation, if you don't know, do bilateral finger thoracostomy. If you're in that unique situation where I don't have x-ray available, I don't have ultrasound available, I have no way to identify quickly if this patient may have a pneumothorax, and I'm not finding any other definite cause of the issue, then do a finger thoracostomy. It's just like you're doing a chest tube, except for it's scalpel, your finger, and you're going in until you find something. You either get the pop because you have air, or you're just going to end up feeling the lung there. And it's a great procedure to know. If you've taken ATLS, you'll learn that. If you haven't taken it before, definitely worth looking at. Then last part. So if it's equipment failure or stacked breaths, you can fix that by taking them off the vent and bagging them. So essentially what I do is I actually do the reverse of this. The first thing I do is I take them off the vent, because if it's equipment failure, I fix that one. And if it's stacked breaths, there's so you get this amazing amount of air that all of a sudden comes out. Sometimes, and this is fascinating, this is fun to do. Sometimes you get patients who have more of that barrel chest and they really are having a hard time. You can actually push down on their chest, and it's almost like a Princess Bride moment where it's like even more air comes out. So sometimes if you think that's what's going on there, you just push down on it. But again, take them off the vent, bag them. That takes care of that problem. Next thing I do is that ultrasound. Again, I'm a big fan of ultrasound, but you can do a chest x-ray instead. And then the last thing. So if those things didn't work, I took them off the vent, that didn't help, I don't see a pneumo, or maybe I did, I corrected, and it's still a problem, then okay, it's probably displacement or obstruction. So displacement, tube's not in the right spot. Obstruction, usually it's because we have this mucus plug that we might be able to sometimes bag through, but doesn't always like really work with you. So you try and suction, inline suction, it's not actually, taking care of it, then the next thing you have to do is replace or exchange the tube. I will warn you, if you have to do this, the very first time that I exchanged a tube, I thought I was going to be clever, quick, and easy. So I put my bougie down, it's all good. I put it through the ET tube. I take the ET tube out. I forgot the fact that they weren't paralyzed. They suddenly bite down, and they are not wanting me to put the new tube in. That was a moment of defecation, I felt like, almost. That's one of those things you want to avoid. So, again, a paralytic can be helpful, a very short-acting, light dose of paralytic. Like I said, succinylcholine can be an option there. But, if you have or can't use it, rocuronium. Just remember, though, if you're using a longer-acting paralytic, you need to really watch the sedation side. But yeah, I'm a big fan of, hey, you have to change the tube out, you have to change the tube out. Just keep in mind, if you are going to do a tube exchange, again, make sure to paralyze them. Don't do what I did the first time. And also, have your airway stuff there, because sometimes things just don't go to plan. And when that happens, you want to be able to actually do laryngoscopy right at that moment and put it back in that way. Again, hopefully you don't have to worry about that, but it is that next step. Between those three interventions, you should be able to fix that person who's crashing on the vent. Speaking of pneumothorax, speaking of focus, this is super, super duper easy, right? I'm looking for lung sliding or no lung sliding. This is like something I can teach someone about 15 minutes or less, where you're looking for something shimmering on the screen, right? You look for rib, shadowing out from the ribs, and then we see that line moving back and forth. That's our lung sliding. That's what I want to see. This is on M mode where I can see it as well. If you have not used ultrasound before, obviously check this out. We actually offer the lung ultrasound for free with our course, so it's something that you can even look at now and check out more later. But with all that said, like I said, there's so many different aspects to it. There's so many components that we could dive into more. It's hard, though, to kind of limit. And what I want to do is I want to take the time to run through a scenario here real quick. So you have a patient that came in significantly sick, right? Normal, otherwise healthy, but you know that this is someone that you have to intubate. And you intubate them, they have initially normal vital signs. You intubate them with ketamine, rocuronium, we're good. For the next 30 or so minutes, it's fine. And then all of a sudden, you start noticing that you've got a little bit of tachycardia, you've got a little bit of hypertension. What should that make you think of? Pain, not adequate sedation, right? Pretty easy, pretty quick to pick up. Not always possible. Now, this person's not moving, so they're not biting against it. They're not causing alarms on the vent yet or anything like that. And instead, you maybe because you're outside the room, because again, 30 minutes has passed. You're probably not still in the room unless it's a really, really sick patient. You've done your bit. You've stepped out. So nursing hasn't noticed that yet. So instead, another 15 or so minutes passes, and now they become really tachycardic. But also, it's because they start bucking, they're fighting the tube and stuff like that. So now what do you have to do? Because we know now that we definitely have missed the sedation window, and now our paralytic has worn off. So what's our next step? What should we do here? Right, you give them medicine, and you do it quick, right? Give them a bolus of something. Give them that fentanyl. You can do fentanyl as a drip and a bolus, right? So give them that bolus there. Now, I know that everyone in this situation, I just told you all not to do this, so you're going to be fine here. But what you find is that, hey, when you actually treat this, guess what? Vital signs start going back to normal. And here's the thing. A little over a year and a couple of months or so, I have a condition known as myasthenia gravis, which you got to learn a little bit about, like it's been touched on just a little bit here. Myasthenia gravis can cause a crisis. So crisis means that the fact that you can't breathe, it's weird because these patients present differently. And by way, I mean also me, right? So it presents differently because it's not like asthma, it's not like COPD, it's not like pneumonia where, we got the guppy breathing type of picture or whatever, right? It's one of those just, well, he looks kind of lazy. He's not really moving a whole lot. Like he's just there on the bed. So, but in this case, so I was actually on shift in my own emergency department. About 5 or so minutes pass. And all of a sudden, I'm not able to breathe on my own. So we do that bit, and luckily some other people notice that, hey, he looks like shit. Met my own criteria. So I met the LLS criteria there. Now, I refuse intubation right away because I'm like, screw this. I already know I'm going to go to my other hospital. So, and this is the one and only time I get to be in a helicopter. Damn it, I'm not going to pay $80,000 and miss out on this ride. So instead, I'm like, no, let's hold off on the ABG. Like, you can do the VBG, that's fine. And it's great because, like, he's like, this asshole is dictating his own care. Like, yes, please. I would really like to be able to do this, but also I want to be able to talk to people and let them know what's going on. So I get flown to the tertiary center. We decide right away to intubate me. And I say we. The only thing I got to decide, I'm like, hey, doc, so this is my only chance of this, and this may be the only time that I get to make this decision. Can we do some ketamine? So doc's like, sure. In fact, karma-wise, I want this to go well for you because I got my own surgery tomorrow, and I want this to go right as rain. So he gives me ketamine. He says he was going to do the intubation himself. Liar, pants on fire here, because the resident comes in who does not know the whole situation. But anyway, I go in the K-hole. Starts out wonderful, right? I have this great dream and stuff. Turns into a geometric hellscape because somehow Legos come into play there. That's its own separate story. But geometric hellscape. And I think, like, it's hard to know because when you have the effects of ketamine, you don't know time, really. It's a mess. So I get ketamine. I'm in this wonderful spot to not so wonderful spot to literally it's all sorts of geometric shapes. I have no idea what's going on. And finally it whites out. I'm like, shit, I'm dead. Like, this is it. Like, this is apparently what the afterlife is like. And it's terrible. Like, I don't like this idea at all. Sorry, I totally blew your speaker there, Chris. Like, it's terrible. So I then flash out of the white to black and realize that I'm not dead. I can hear the nurses talking back and forth. And I wake up at the exact moment that a Foley catheter is being inserted. The ketamine's gone, damn it! So, but the rocuronium is still doing its job wunderbar. So I can't move, can't do anything. It takes about somewhere between 5 and 10 minutes, because again, my eyes aren't open, right? I can't do anything. I have this incredible pain of having that thing shoved in the back of my throat. Remember, I have a terrible fucking gag reflex, so this is terrible on me. Like, this is not going well at all. So I've got this gag reflex. I got this going on. I can't do anything. I can't signal to anyone. And about 10 minutes passes before anyone notices that, hey, he's tachycardic. Hey, he's even got some tears. So then I get the pity moment that, oh, like, yeah, exactly. I'm like, damn it, just knock me out. So over the next about 15 or so minutes or more, my wife's there at this point, so she can tell me more. But anyway, it takes a while to knock me down with the propofol because, again, we're trying to do this ease, right, and stuff like that. And then, like, thank God for the propofol part because once I was out until the following morning. But then as I was getting extubated, they took a long time to extubate me. And they wanted to make sure that I was waking up okay and stuff like that. But they forgot to continue with the pain medicine side. So I have propofol, that's fine. But the propofol is gone, and there's nothing for analgesia there. And I'm back to this gagging like, oh my, like something's here. I can't talk. And so I'm trying to signal the whole time, like, hey, this is what's going on. And one of the lovely nurses, she's like baby nurse, brand new nurse, right? And the nurse that she's paired up with, is kind of that classical, we all know the type. The nurse who's just like, I know exactly what I'm doing, and here we go. But the baby nurse actually takes the time to look at my chart, realizes like, hey, he's on the spectrum, like he can communicate here, so maybe he knows sign language. And there was the oh shit moment, I wish I learned sign language before this point. But it didn't matter anyway, because no one else in the room knew sign language either. So I'm trying to spell out my wife's name, but the only thing I know is A for, A, right? Then Didn't get any further than that. I probably should have learned that by now. But like I'm trying to get attention, but luckily someone was smart enough to realize, hey, let's have a little whiteboard, write messages. The messages, by the way, were awful. Didn't make a whole lot of sense. But all of this to say, these comedy of errors and stuff like that could have easily been prevented had we just had a little more time to think about that sedation, the management. So all this is to culminate to the reason why I've got to talk to you for 2 hours on airway management is to tell you that, like, talking from this perspective, and keep in mind, I've always been an advocate for this. I've always been an advocate for intubation, proper sedation, stuff like that. Thinking that hopefully karma worked out well for me. And it sucked, right? It was painful, it was terrible, it was terrifying to be on that end. So just please remember, it's something you could do. Yeah. All right, well, that sucks. So anyway, I gotta have the next joke, and I lost the joke, so that's the bad part. Anyway, so just know that really, it really affects people in weird ways. I still get randomly the dreams from the ketamine, so it's really weird. I was gonna do better with this, but I lost track. So, anyway, it's one of those things, I want you to remember this. I hope you're never in the same spot. It's really painful. It really sucks. And it's something you can easily fix. Whew. All right, so I'm going to have some kind of joke or something at the end here to fix this. I don't know what it is. But just remember that, if you want to learn more about ultrasound, you can come straight to me. 20% discount, CCME, right, for the next week or so. After that, it's like, I think we're going to do like a 10% discount or something. So that gets me happy because I get to talk about ultrasound. But no, really, I appreciate everyone taking the time, sticking around for this because, again, it's great, like seeing the dwindling numbers. It's like, and then there were none. But not my favorite Agatha Christie book, but it's still decent. But anyway, I again appreciate you taking the time, coming here, learning this stuff. Oh my God, am I the last person here? Everyone else booked out apparently, but I will stick around and answer questions. I think Martha's somewhere around here. But feel free. Otherwise, safe travels. Thank you for coming to Las Vegas. And we have the December EM Boot Camp, which is the original EM Boot Camp. That comes up here. What are the dates again? I think it's 2nd and 3rd for the ultrasound and pre-conference stuff, and then it's the 4th, 5th, and 6th for the regular course here. And if I mess it up, Rick will probably get on me. But actually not. He's a super cool guy. Anyway, safe travels. Thank you so much for coming, and we'll see you next time.